Hello, this is Rick Alber. I'm going to moderate today's webinar presented by the CMT Association. This is the third of a series of webinars, and today's guest is James Nussbaum. James is a physical therapist that's going to talk about current treatments and physical therapeutic approach to the CMT disease. James is a PhD, a physical therapist, and his title is Clinical and Research Director for ProHealth PT. I think James can tell us a little bit more about his background in just a moment when I introduce him. During today's webinar, which should last about maybe an hour and 20 minutes, we think, James will give a presentation about ProHealth and fitness for CMT folks. And following his formal presentation, he will answer a series of questions. We've had some questions submitted to us before today via email from attendees, and during today's presentation you're welcome to type in questions on the webinar dashboard that should be appearing on your screen. At the end of the formal presentation, as I said, I will put together those questions and we'll answer just as many of them as we can in the time allotted. So what else? Oh, and by the in the next week or so, we should have this presentation up and available for viewing on the CMTA website at cmtausa.org. Along with a transcript of what's said here and a copy of James's slides that you will see during the presentation. If you have any other questions, please submit them in the question box, and I'll try to address those, as I said, at the end of the presentation, or if it's a question having to do with the webinar, I'll send you a private chat message addressing the question. So with that, I'd like to introduce James Nussbaum and welcome him to the webinar.
I'm very much looking forward to this webinar, and of course want to thank Herb and Pat and Rick and everybody else for giving me this opportunity. I reviewed some of the questions that people wrote in, and as Rick said, you'll have the opportunity to keep on asking. I hope to address all of them in my talk, and certainly afterward when we have some more informal back and forth. So as you know, we're going to be talking about Charcot-Marie-Tooth and skilled physical therapy and exercise to improve function and quality of life in CMT. There's a quote that every patient with CMT should be evaluated by a skilled physical and occupational therapist. And if you saw the advertisement or the blurb about today, well, we're going to be talking about skilled PT and OT to improve function and quality of life in CMT, and I'll discuss some of the therapeutic benefits, cardiovascular exercise, resistance work, balance, functional exercise guidelines, and some of the literature behind all of these things. And the discussion will include some tips for people of all ages with specific individual advice and exercise, and therapeutic recommendation, of course, can only be made individually. Disclaimer, I'm going to be talking about my opinion. My opinion is based on my clinical experience, my opinion is based on my education and my understanding of the literature, but there are those who disagree, so please understand that. Of course, all exercise and activities should be cleared by an expert, usually your neurologist. Consult your physician prior to engaging in any new activity. But of course, you can ask your doctor to speak with another expert, because that's usually a great way to go about things. There is no sponsor, pharmaceutical or otherwise, and I have no interests that I need to disclose. So that quote, every patient with CMT should be evaluated by a skilled physical and occupational therapist. The author of that quote is someone with whom I spend lots and lots and lots of time every single day. Over the course of the next hour and a bit, I'll give you a little bit of background about myself. We'll define some terms. We'll discuss some common impairments, review a little bit of literature, probably have more literature there than you want, but this way we'll just improve function via exercise and therapy. We'll summarize a little bit, and again, as I said before, we'll answer some questions, or we'll certainly try. What I won't be talking about today is the genetics, the pathophysiology, nutrition, and some other things in which I'm not at all an expert. And if that's what you're planning on asking me, you probably can find out better information by speaking to your physician, maybe even going online, because that's not my area of expertise. A little bit about myself. I've been an instructor for the American Red Cross for the past 27 years in a variety of things, CPR, water safety, and the like. I'm an active emergency medical technician, a crew chief on an ambulance through the New York State Department of Health. I was for a number of years as a health and fitness specialist. I got my bachelor's in health science, my master's in physical therapy, my doctorate in pathokinesiology. I was certified by the National Strength and Conditioning Association as a certified strength and condition specialist. I previously worked for the New York City Department of Education as a senior physical therapist within the school system. I worked for the American Physical Therapy Association as a sports specialist. I'm a clinical instructor for a number of physical therapy schools. I sit on numerous advisory boards, including the CMTA. I am the co-director of research at Triarc, a wonderful organization that was formed to help with the collaboration of physicians and therapists to improve patient outcomes. And I've been fortunate enough and honored to have presented some of my research in Berlin, Beijing, Barcelona, around the world and throughout the United States, mostly on physical therapy and exercise and trying to improve patient outcomes through those means. That's, in a nutshell, why I'm talking to you today. There's another quote by someone with whom I spend all of my time and who's talking to you today. The primary goal of a healthcare provider should be to improve quality of life. I believe that very, very strongly. Well, what impacts quality of life? It's different for all of us. Maybe independence, mobility, comforts, being in control of our lives. And each healthcare practitioner, each specialist, plays her or his part in working with their patient to improve quality of life in the way in which they know how in their area of specialty, in their domain. My personal goal and the goal of ProHealth and Fitness PTOT when we're working with all patients are to improve functional independence, to promote activity tolerance, to enhance mobility, to make activities of daily living more doable, to try to get people to be able to participate in recreational activities, ultimately to enable patients to have choices. Too many people with a variety of problems, not necessarily CMT alone, start having their worlds shrink, or they sometimes shrink their own worlds because of physical and sometimes other ailments. It is my goal as a physical therapist and my goal as a clinical director for my physical and occupational therapists, researchers, to try to enable people to expand their world and to have more choices. Who are the experts in testing and improving function so that people can, in fact, expand their worlds? I would tell you, physical and occupational therapists. Let's define some terms. Exercise. Physical exercise is any bodily activity that enhances or maintains physical fitness and overall health and wellness. It's performed for a variety of reasons, including strengthening muscles in the cardiovascular system, honing athletic skills, weight loss or maintenance, body composition, as well as for the purpose of enjoyment. And I'm sure there are some people smiling. People enjoy exercise. Physical therapy or physiotherapy is a healthcare profession primarily concerned with the remediation of impairments and disabilities and the promotion of mobility, functional ability and quality of life, and movement potential through examination, evaluation, diagnosis, and physical intervention. Where did I get these definitions? I got these definitions from the the definition experts of the world. You can just ask my children from Wikipedia. If I were to give you a definition that maybe is slightly different, I would tell you that exercise, besides being something that we should all do, and we should all do daily, and we should do it with a purpose, with a goal, and understanding a little bit of the science behind why we're doing what we're doing, is overloading the body in some way, or causing the body to work with a level of intensity which causes a change. That change might be fatigue, increased blood flow, elevated heart rate, lots of things. And we might do it for a variety of reasons. I would define PT as a profession or professionals whose goal it is to help their patients improve their function, independence, and physically related quality of life through numerous skilled modalities. In my experience, and we're going to get to this a little bit later, balance, falls, fear of falling is so important in patients with Charcot-Marie-Tooth. And I therefore want to just define a fall. A fall, according to the World Health Organization, is an event which results in a person coming to rest inadvertently on the ground or another lower level. What does that mean? That means you don't have to kind of fall on the ice. If you didn't mean to slowly start to fall or quickly start to fall and need to catch yourself on the wall, and you didn't fall as we would normally define, according to the World Health Organization, that's a fall. So what are the impairments that we commonly see in patients with a diagnosis of Charcot-Marie-Tooth? There may be pain, fatigue, weakness, muscle loss, sensory loss, imbalance, and falls, as I just mentioned, which are extremely important to me and very interesting to try to understand and treat. Joint deformities, autonomic dysfunction, blood pressure regulation, heart rate variability, temperature control. One thing that's incredibly important to be reminded of are the comorbidities. Just because someone has a diagnosis of CMT, it doesn't mean they don't have anything else. And other medical health problems may complicate the things that are going on with CMT and may need to be addressed as well. And this is something that I believe is important and not to be overlooked. So we have all these impairments. And we have different things, and some of the things might be relevant to those of you listening and to your loved ones, and maybe not. Everyone's different. We all present in different ways. However, what impact does that have on our lives? How does it impact our function? How does that impact our independence and ultimately our quality of life? And I think that that's the way that we think about these things as human beings. I would hope that as healthcare practitioners, such as myself, that that's the way in which we think about these impairments in an effort to better serve our patients. Let's look at the literature. Let's see what we can find when we delve into our computers, if there's any of us that still go to libraries, what we might find. Interestingly, PubMed is a great site to look at peer-reviewed literature, and clinical trials is another one. There are many such sites. And if you look at Parkinson's disease and exercise, you'll see 957 citations, or maybe that's what it was 2, 3, 4 days ago when I was preparing and finalizing my slides. If you look at multiple sclerosis and exercise, 853 citations in the literature. If you look at CMT and exercise, you'll see somewhere between 40 and 53 citations. Why is it not exact? Well, because some of them are for other diseases and other problems with the same abbreviation, CMT. But that's a marked difference between the 900 or so citations for some other neurological, progressive, chronic disorders and CMT that has really just a few dozen. Well, when we look at those 40, 50 studies, what does it tell us? Is exercise good or is exercise bad? And that seems like that's the ultimate question that everyone seems to be asking. the question that we're trying to find out in the literature, we're trying to discuss today, and trying to get resolved. Is there a consensus in the literature? Unfortunately not. And just to fast forward for a second, I'm not going to give you a great answer today as far as this is what you should do. However, I'm going to tell you that we should all exercise, and there's no question in my mind that that's correct, but there are those that may not agree with me. When we look in the literature, there's some important names to pay attention to. Of course, the CMTA's very own Dr. Shai, Scherer, and others. You can see Dr. Chetland, Muth, and go on and on. There was a recent CMTA newsletter with an article by a patient with some help. And my favorite happens to be Gita out of the UK, who's a physiotherapist who's written extensively and may be the expert on physical therapy and exercise in patients with CMT. And this is for you to go ahead and take a look on your own and gather some information. When I put in strength training and CMT, I actually got 10 hits on PubMed, even worse. And I think that was last night. Why so few? Why the dilemmas? Why the confusion? Well, the one biggest possible pitfall out there is something called overwork weakness. What does that really mean to us? That means that the possibility, the theory, the hypothesis, that if I do too much, I'm actually going to get myself weaker and less functional and less independent and have a poorer quality of life. What happens? What's going on that could possibly make weakness the result of overwork? We're not sure. It might be chemical, structural, electrical, neurological. We don't know. Some of the major research looking into overwork weakness currently and in the last few years is related to dominant hand versus non-dominant hand strength. In theory, if there was overwork weakness, and if I, as a right-handed individual, use my right hand more, then the overwork that my right hand is getting from being used more would ultimately lead to it becoming weaker. And therefore, when I check my strength on my dominant versus non-dominant hand, in theory, CMT and overwork weakness would make my non-dominant hand stronger. But once again, there is no consensus. This debate on overwork weakness started long ago, 50, 60, 70 years ago. And here are just some citations for some of the studies, some more recent, some older, and you can go on your own and take a look at those at your leisure. Very many of these studies that are often cited in those that are hesitant or skeptical to advise patients to exercise have very, very, very few participants, and therefore the power of their studies are somewhat suspect. However, I must admit, on the flip side, some of the studies showing the benefits and the reasons to exercise might be just as suspect. These 4 studies are possibly the most quoted and paid. You might be smart to go ahead and take a look if this is something that in fact you're interested in. One that I wanted to bring a little bit more light to is a recent study in 2009 in the Journal of Rehabilitation Medicine, the hypothesis of overwork weakness in CMT. It's been reported that the non-dominant hand of patients with CMT is stronger than the dominant hand as a result of overwork weakness. The objective of this study was to determine if this hypothesis could be verified in our population. These folks were looking at patients in the Netherlands. And they concluded the dominant hand of patients with CMT, type 1 and 2, was equally strong as the non-dominant hand, suggesting that there was no presence of overwork weakness in their patients. This implies that the patients with CMT do not have to limit the use of their hands in daily life in order to prevent muscle strength loss. Interesting, but of course there are studies on the other side of that fence, as I mentioned. What does some of the other literature say? It talks about autonomic dysfunction, as I mentioned before. Particularly, exercise training improves autonomic profiles in patients with CMT. And this was in Muscle and Nerve, as you can see, just a couple of years ago. Unfortunately, only 8 patients. But they found that interval training improves heart rate variability. by increasing something called parasympathetic activity. And that's getting probably a little bit much into the physiology, but it's an important thing to understand of some potential benefits of exercise. Strengthen muscle fibers. This is possibly one of my favorite ones, and that certainly addresses some people's questions. Resistance training, exercise, and creatine supplementation in patients with CMT. They ultimately found in this particular study that the creatine didn't really help. However, that patients respond to resistance training with actual muscle fiber adaptations, positive changes in muscle, and subsequent improvements in strength and function. Sounds too good to be true. Most things that are too good to be true are, in fact, too good to be true. But that's Chatlin, who's written lots on the topic, who's made many recommendations for exercise, both cardiovascular and resistance, as well as functional activities. Speaking of activities of daily living, again, Chatlin, resistance training effectiveness in patients with CMT, recommendations for exercise. 12 weeks, home-based resistance training program. Found it improved strength and ADLs, activities of daily living, in both women as well as men. Outcome measures, something that we'll be talking a bunch about shortly. Outcome measures in rehabilitation treatment in patients affected by Charcot-Marie-Tooth. Pilot study. Again, only 8 participants. Not so good when you don't have a large sample size. Twice weekly activities for 8 weeks, and it quotes, there were no dropouts or worsening in any of the different outcome measures after their program. That's an abbreviation for their multifactorial program. And the ankle angle, or for many of you that know the lingo, the dorsiflexion, the way in which the top of the foot angles with the shin, and the time to walk 6 meters were the only measures that significantly improved after treatment. Outcome measures are measures that clinicians use to see how patients are doing, and we'll talk a little bit more, as I said. So we looked at some literature, highlighted some things. There's so much more. We could spend a couple of days talking about it, even with the paucity of literature that exists. Are there robust studies? Not really. Is there unequivocal evidence that therapy is fantastic and exercise is great? Are there clear programmatic protocols? No, there are not, unfortunately. Have there been white papers and recommendations? There are actually a couple, but are any of them clearly based on sound literature that we can all be so comfortable to hang our hat on? I don't think so. But does that mean that people with CMT should not exercise? Absolutely not. It makes no sense not to. So how do we bridge the gap between some literature, some confusion, and practice? What do we do? Well, we find the CMT Center of Excellence. Going to the CMT site will help you in finding the Center of Excellence. Consult with the experts. That's what we do, right, when we have an issue. Be proactive. Don't just sit around and wait for the answers to come to you. Support the association. Be active. Support groups. Financially, whatever you can do. The words always and never should not be used too often, because most things don't fit into such strong boundaries as always and never. Find skilled physical and occupational therapists and get evaluated. Every patient with CMT should have an evaluation by a physical therapist and an occupational therapist. Everyone should exercise. Everyone with CMT should exercise. Everyone should exercise because exercise is good, and it's good for everyone. It's good for everyone at the right time, in the right dose, using the right mode, with the appropriate intensity, proper rest periods under the skilled guidance and supervision of an expert. Those are bold statements, and I'm confident that they're true, but not everyone agrees. Use the experts in function. Who are the experts in function? Physical and occupational therapists, as I mentioned. If you want to improve your function using therapy, exercise, then go to the people who know about those things, physical and occupational therapists. However, don't ever neglect the team, the patient themselves. Got to listen to the patient. The family, Some people have home health aides, social workers, the neurologist, of course, who can really help to guide, limit, set boundaries, inform on precautions and or contraindications, and it should be a dialogue. Physiatry, orthopedists, orthotists, and prosthetists, if relevant. Rheumatologists, cardiologists, pulmonologists, psych, so many people, because as I mentioned before, there may be comorbidities, and some of them comorbidities may impact what the therapist can do exercise-wise or otherwise for a particular patient. So the communication and the collaboration of this team is incredibly important. And once again, cannot be underthought, underutilized, and such. So, okay, I've convinced you. I want to give this a try now. What do I do? Well, find a skilled PT and OT and get an evaluation. Speak to your doctor, get a prescription. Whoa, insurance, is it going to be covered? How much does it cost? What do I do about all this stuff? That's another entire webinar, probably a full-day webinar, because today versus next week or 2 weeks, things will change. And they're literally changing by the minute in terms of Medicare beneficiaries, in terms of Obamacare changes, in terms of the commercial insurers, and lots of things. So that's a very, very individual item to be addressed. It's incredibly important, and it's something that we will not discuss any further than that, except to say that, in my opinion, finding out that information is incredibly important so that you can make informed decisions. Okay, so I want to make functional change. I decided I'm going to get evaluation. What's going to happen there? Well, the therapist is going to identify deficits. He's going to identify things that are problematic, things that are difficult, things that are not what they used to be. You have to listen to the patient. You have to skillfully look at function as a whole, function individually, and really try to understand what's going on. You need to use outcome measures because they're valid, they're objective, and they're reliable. And this way you can see where somebody is compared to themselves, compared to others, compared to norms, and so forth. Then, after the evaluation, there'll be interventions. The therapist will intervene. They'll treat the patient 2 times a week, 3 times a week, 1 time a week, one time a month, and have the patient do things on their own, whatever it might be. But once again, you need to listen to the patient, ask them how they're doing. Ask them how it was after last time. How did they feel? Were they sore? Was the homework that they had easy to do? Skillfully look at function again. Are there changes? Repeat outcome measures from time to time because they're objective, valid, and reliable. So it's not only the clinician's opinion, but it's fact. And reassess and take a look at progress and make changes accordingly. I need to just throw this slide up there for a moment about occupational therapy, my colleagues. I understand that my title is Physical Therapy and Exercise, as I am a physical therapist. However, we work directly and closely with our occupational therapy colleagues, and their evaluation and their intervention ultimately is a little bit more focused on activities of daily living, both basic and instrumental, such as grooming, dressing, feeding, writing, bathing, and these types of things. Fine motor control, intrinsic muscle strength, dexterity and coordination, often of the hands, trunk, shoulder, elbow, and hand function, and they try to improve motion with mobilization, and PNF stands for proprioceptive neuromuscular facilitation. I would expect everyone to email me afterward with the correct spelling of that. A certain technique that helps with a lot of different things, and decreasing pain if present with modalities, strengthening with therapeutic activities, as well as exercise. And that's some of the many things that our OTs do for our patients. When I ultimately try to find an exercise program for my patients, I need to consider lots and lots and lots of things. Program design is a science, and there are many things that go into it. There are different types of exercise, aerobic and anaerobic. There are different energy systems in which I can gain energy. And I want to identify where I'm getting my energy from, what am I trying to accomplish, what can I do to accomplish that particular goal. And there's science. Is the science perfect? No. Is the science well full of literature particular to exercise in patients with Charcot-Marie-Tooth? We've already established that it is not. So we use clinical experience and reasoning. We use the literature on folks with other similar diseases. We use the literature on, put in quotes, normals, if there are any. And we try to apply it as best as we can clinically to our patients with Charcot-Marie-Tooth. The skilled physical and therapy intervention and evaluation involves some of the following. You evaluate the patient with these outcome measures that I mentioned. You send a summary of the evaluation with the plan to the physician, to the neurologist, to maybe some of the others that I mentioned before, and say, hey, this is what I found in your patient. This is what I would like to do. Is there anything you think is a bad idea? Let's talk about this patient. Let's work together to try to improve their quality of life. How are we going to do that? Therapeutic activities, transfer training, working on sitting to standing, working on negotiating curbs, rolling in bed, assistive device fitting if appropriate, and utilization, when, how, why, orthotic management if necessary, to recommend, to not recommend, the fit, usage, neuromuscular re-education, balance activities, posture, really encompasses a lot of what we do. Manual techniques, soft tissue work, massage, joint mobilization to treat pain, contractures, immobility, tissue dysfunction, and so forth. Therapeutic modalities, electrical stimulation, ultrasound, cold laser, near-infrared phototherapy, thermal modalities, more. There's lots of different things, and that will not be the focus of today. And of course, therapeutic exercise, using sound program design principles as well as an appropriate home exercise program, HEP, home exercise program for the patient that myself as the clinician is comfortable that they can do properly, independently, without doing too much, and therefore getting feedback afterward to find out how it went, how they felt, and so forth. During the evaluation, we identify deficits, like I said. We make short and long-term goals. We have a plan of care, as I mentioned, with the opportunity to communicate with the physician. And we ultimately implement what we plan to do, and we check progress at regular intervals. One of the objective things is you got to know the anatomy as a therapist and understand how your patient presents. And this is just one slide that might be familiar to you. And different dermatomes, or ways in which nerves manifest themselves or represent themselves on the surface, give us information on sensation. This is a sensory chart. There's also movement or motor charts. And this is something that's very important to take a look at. During the evaluation, you can take a subjective history, objective measures, make an assessment and a plan, using outcome measures, clinical tests, functional tests, questionnaires, but they're repeatable as mentioned. Some of the balance and fall-related assessments are something called the timed up and go. That's the first one on your screen. Gait speed. Normal gait speed, which in the literature is spoken about in meters per second, is actually being called the sixth vital sign because it is so important, so easy to do, so repeatable, and the information that it gives for morbidity and mortality, for death and hospitalizations, is comparable to that of blood pressure, which is fantastic. And all these tests mentioned here have their place, and they give the clinician information on the fall risk of a particular patient and of the current functional status in that domain. Speaking about falls for a quick moment, there was an excellent review article by Sherrington in JAGS, in the Journal of American Geriatric Society, that demonstrated that you can actually prevent falls. Not all of them, between 30 and 35% of falls, particularly in an over 65 population. And we'll get to that again a little bit later, I hope. Therapeutic exercise. So I keep talking about program design. What's safe, what's not? Well, we have to understand there are principles. What mode? What am I doing? Am I sitting on a bike? Am I lifting weights? Am I running on a track? Am I using a kettlebell? Am I using a vibration platform? What am I doing? How many repetitions? How many sets? What intensity? How hard is it for me? How long am I resting? How often do I do it every week? What's my total volume of repetitions and sets and frequency and so forth. And how do all these things relate to the safety? What energy system am I using? Am I trying to use that particular energy system? One of the most important things that's discussed in the literature and that people are afraid of in CMT and exercise is intensity. How hard should I work? Is it safe? Can I push myself? What can I do? How do we measure intensity? Well, for people that are not taking certain drugs that mute a heart rate response, we can check heart rate. And what we do in our clinics is we have these little finger pulse oximeters that right when someone is doing something and or when they're finished and during rest periods, we monitor heart rates to see how they're doing. We also monitor pulse oximetry. What percentage of it is from their repetition maximum? If someone is lifting a gallon of water, because that's a functional activity, and I want them to be able to put it in the top shelf of their refrigerator, well, when they lift that up, at what percentage of their ability to lift the maximum weight item is that? And there are formulas to figure that out. And what's safe? RPE, rate of perceived exertion, is perhaps the most widely used measure of intensity, and that's often done as a modification on what's called the Borg scale. Simply put, ask the patient, how difficult was that for you? 1 to 10, 10 being the most difficult. And this is something that can be tracked over time. What are the work-rest intervals and ratios? I want to assess all these things and modify, be flexible. I need to have a goal. I need to build upon success, and slow and steady usually wins the race. Is my therapy and my treatment, a direct approach or an indirect approach? Am I directly improving nerves and muscles? Sometimes. Am I directly improving a clear limitation? Someone who has foot drop, for example. Someone whose foot kind of just falls down and cannot lift their toes towards their shin. May I be able to strengthen the muscles that can do that so that later on they can in fact do that and walk a little bit better, more efficiently? Maybe. Sometimes I say, you know what? I don't want to spend my time with my patient doing that because I don't think it's going to work. Or the neurologist tells me, you know what, James, it's not going to work. Don't spend the time doing that. So I might teach the patient an indirect approach. I might teach them when they walk to lift their knee a little bit higher so that they don't fall, because maybe I think for this patient, AFOs, ankle foot orthoses, or braces for their feet and ankles, are not the best approach. And that's something that people asked about, and it's incredibly individualized. I, for one, love to not use braces when I can with my patients, because I love for my patient to be able to feel the floor with the sensation that they have, and I think that's very, very beneficial. However, sometimes it's a matter of safety, and very often it's not so clear, and there are reasons to brace and not to brace. There are direct approaches and there are indirect approaches to patient care, to treatment, to improving quality of life. What are my exercise choices? Oh, there's some AFOs for you. Simple movements, uni-joint, single joint motions, or complex joints. Standing and sitting. I probably lost you in the camera there. Should I do the simple ones first and then move to complex? Should I go to complex and then simple? The literature is not so clear. OKC, open kinetic chain. Taking my foot or my hand and moving it in free space, unadulterated, wherever it wants to go, or closed chain, fixed, standing on the floor, pressing against a wall, or something, which would be considered closed chain. Again, I want to look at the program design principles, mode, volume, intensity, frequency, rest, and so on. In the presence of pathology, how does CMT affect all of these decisions? The literature is not so clear, but there are some fundamental principles that we're about to get to. So what do I do when I'm choosing exercises? Do's and don'ts. Are there some things that I should definitely not do and some things that I should do? Some of you might be looking at that picture saying, oh, I'm not sitting on that ball. Hell no, that's not for me. I'm going to fall right off. Some people might fall right off, and maybe that's why the therapist is there to help them and to stabilize. And ultimately, we can work on some muscles and movements and things that work a little bit better, and ooh, great spelling there, and gain and improve and be safe. Who is this not appropriate for? Well, maybe she has CMT, but she also had hip replacement, and that angle of the hip that you see there is not okay. So we can never forget the comorbidities into some of our choices and decisions and this whole discussion here. People tell me the water is the best place to exercise. Said who? Is it good? Absolutely. That's me with the little boy that I'm working with in the water. And I think it's a great thing and a great medium. But we don't live in the water, so it's certainly not a be-all, end-all. It's a great place for mobility. It's a great place for balance. It's a great place to unweight and even for pain relief. However, if we want to improve function, we need to also exercise, have therapy, work outside of the water, because most of us do not live in the water. That's why it's dangerous to say never and always. I have patients who tell me, oh, the bike is bad for your knees. The bike is not bad for your knees. The bike might be bad for your knees. The bike might be bad for your knees at the seat height and the pedal distance that you use on your bike. The bike is not bad for your knees. And everything could potentially be adjusted and modified. Do we talk about movements or muscles when we talk about exercise and therapy? Synergistic muscles, muscles that kind of work together for certain movements. Agonists, muscles that work together, all things that bend my elbow. Antagonists, muscles on the other side that would straighten it or preventing me from bending. Open chain and closed chain, as we discussed. Concentric, eccentric, shortening and lengthening. Stability versus mobility, length-tension relationships. These are some of the underlying factors to the decisions that we make as therapists with our patients. Particularly lower extremity, but not necessarily, versus upper extremity, we have many of the same considerations. Let's talk a little bit about some specific exercises. One of my favorite exercises is a lunge. That doesn't mean that I think that everyone should do a lunge, can do a lunge, do it with weights, do it at this foot distance, be able to maintain a vertical orientation of their trunk like this skinless gentleman. I'm not sure that I can say it's a gentleman, but looks like it. But versions of the lunge are incredibly basic to function. We lunge when we get off the floor on some level. We lunge when we catch ourselves in a moment of imbalance in some capacity, and therefore doing it and getting better at it is incredibly important. Modifications, flexibility, adjustments are the way in which to make exercise and physical therapy work functional, appropriate, and beneficial to every single patient. The squat, or a version of the squat, is something that we do, most of us, all of the time. Take a look. Can I do it with such a fantastic straight back like this gentleman? Maybe not. I might have some joint deformities, stiffness, problems that don't let my ankle get into that angle, so I need to adjust accordingly. But every time I get out of a chair or try to get out of a chair, I'm doing some version of a squat, which is extremely important, and therefore, if I want to improve my function, I need to find a way in which to do this. Balance. One of my favorite topics, and one in which I think balance and fatigue, I think, are some of the most important topics to discuss in the realm of physical therapy, exercise, and Charcot-Marie-Tooth. And we use the BioDex balance system among many, many, many other things to assess and work on balance in our patients. And that's just a picture of a fine gentleman on the machine. What he's standing on there is a force plate, and it can sense, if you will, and put that word in quotes, where the pressure of his feet is on that plate, and it will give him a visual representation of that, which he can manipulate with the biofeedback of vision. Now, there are people, of course, that are visually impaired, and therefore we can't use vision to help them, and therefore need other means. But vision, when available, is a fantastic compensatory mechanism to utilize for imbalance, particularly imbalance that stems from some sensory compromise in the feet and the legs. When I look at things, I want to understand where emotion's coming from. Is that what I want someone to do? Maybe. Just because someone's bending down to touch their toes, well, they might be bending their back, not their hips, their knees, their ankles, and so on. And what are the restraints? What are passive and active? What are they to do? What's happening? Stability. These are getting a little bit into some specific terms, but just to give you a glimpse into it, flexibility to me is how easy is it for me to take your knee and make it straight, or your ankle and make it bend, versus range of motion, let me take a measurement when I get there. And what does the numbers say? What am I shooting for? What am I doing and why? Balance exercises can include lots of the following things. unilateral stance, standing on one leg or trying, with and without support, with eyes open and with eyes closed. Proprioception is the ability to kind of sense where you are in space. These are high-level activities that you see here. And we will sometimes do high-level activities, having people have moments of imbalance and start to fall under the guidance and care of a therapist who will make sure that they don't fall and work on the strategies necessary to compensate for the initiation of a fall, to deal with moments of imbalance so that these reactions ultimately become timely, efficient, and productive. Machines versus no machines. I got a lot of questions on machines. Well, we have a lot of nice machines in our facilities at ProHealth. We're very proud of them. But for some people they're good, for some people they're not good. Most people, there's a machine that can be helpful along with other things. You see in the literature a lot, oh, machines or dumbbells, those are dangerous. Use your body weight. For many people, your body weight is much more intense than using a machine or a dumbbell or something else. Weigh 225. A lot of weight. That might be too much for me. That might cause me trouble. I might be able to go on a machine that simulates that motion where I can cut it in half or even less and ultimately build up, if we feel it's safe to a more rigorous weight or resistance level. When we think about exercising, we need to think about a risk-benefit ratio. So this nice young lady is going into a deep squat. She has fantastic back position. Her knees are well aligned, and she's going to jump up and come back down into the squat. Is that a great idea for lots of people? I don't think so. If I was a volleyball player, or if I was trying to improve my ability to participate in certain athletics, absolutely, as long as I weigh the risks. For most people, not everyone, but for most people with the diagnosis of CMT, this is not such a good idea. It's a little bit too intense, and the risks outweigh the benefits. We could probably try to understand other ways to do similar motions without as much stress on joints, ligaments, tendons, and so forth. But ultimately, we need to look at the goal, we need to look at the current condition of someone, and we need to monitor how they respond to, at first, small levels of stress, and then slowly increasing levels of stress to identify the appropriate intensity, volume, frequency, and so forth of intervention and exercise to attain our goals. That's the view from my office at Johnson & Johnson. Nice view, poor pay, great job. I know that we can work together to make a difference. Patients, therapists, the association. Call a local therapist today. Communication is key between you and the therapist, your doctor and the therapist, you and your doctor, and so forth. It can be done. The only way for us to get more of a consensus and have more research out there is for patients to be seen and for patients to be evaluated utilizing outcome measures that are objective and valid. I am confident that through skilled therapy, falls can be prevented, not totally, but minimized. Activities of daily living can be made more independent. Mobility can increase, community access can be enjoyed, and ultimately quality of life can be improved. It starts with evaluation. Healthcare is quality of life. It's what it's all about. It needs to be about. As a healthcare practitioner who sees patients with a variety of ailments, I know that medicine and healthcare are often focused on keeping people alive. I think we need to focus on helping people live. There's a long road ahead. There's a lot to do. There's a lot of research to be done, not only in genetics, but on the ground. How can we help the people right here, right now? But it takes a lot of work, and hopefully together we can do some of that work. There's a lot of questions, and I hope I addressed many of them with my talk. I have plenty more slides and things to share with you, but what I'll do for right now is I'm going to hand the floor over to Rick to maybe summarize some of the questions, because I'm exactly 50 minutes into the presentation, and I will address as many of the questions as possible. Any questions that I do not address, or you don't like what I say, or you disagree with me, and you say I'm out of my mind, which is possible and probable, please feel free to email me. I hope to get back to you in a timely manner. I thank you for listening to the formal part of the presentation, and I hope over the next few minutes to be able to answer and address as many questions as I possibly can. Before I hand over fully to Rick and then address him, I just want to mention one question that we got, and again, thank you for your questions because there were so many. Someone literally said, how do I know when to start seeing a physical therapist with this disease? Now, yesterday, if you feel fantastic and you're doing everything really well, and for some reason you knew it through your family, you had something and you went to the doctor and you were tested and you have a diagnosis. If we don't get a picture of how you're doing right now through objective measures, Dr. Shai has a fantastic neuropathy scale, and if it's accompanied with other functional measures, we can get a snapshot of where you are right now. Whether you're a child, an adult, where do you function right now? And ultimately compare you to yourself as well as to norms and established data, so that we can see what you're doing and how it is and how you progress. The sooner everyone gets a physical and occupational therapy evaluation that is sound, that utilizes these measures, we can see when something changes. Sometimes we make accommodations for ourselves. And sometimes we say, you know what, it's a little bit hard to go to the grocery store. I'll send my husband. I'll send my kids. My neighbor's going anyway. She'll go. Before I know it, I can't go anymore. And I missed that kind of timeline where I was on the fence when otherwise I might have intervened. Go get an evaluation. That doesn't mean you need therapy. It doesn't mean you need to go and commit to anything. Get a baseline measure. It's incredibly important. Rick, go ahead, please, and I will answer as much as I can, as best as I can. Thank you so much.
Well, thanks very much, James. I think everybody would agree that that was an incredibly complete and easy to understand and entertaining presentation that I'm so glad we were able to get some of your time today to do this webinar.
Thank you for your kind words.
Absolutely. Thank you for putting in the time to think about this and organize your thoughts so well. We've got about 15, maybe 20 questions perhaps that have come in before the presentation and during the presentation. A lot of the questions that came in prior to the presentation, I believe, have been answered quite fully in your the last 50 minutes. And I'll skip over a lot of those that I think you've addressed. However, some of the questions that came in before are more specific or delve into details that I think you might want to elaborate on. So I'll start with the first question about exercising. And it says, I've been diagnosed with CMT in the last 2 years and always enjoyed walking, sometimes up to 6 miles a day. Now, however, I struggle to do half a mile with many sit-downs. What would you suggest to replace what walking gave me, that is cardiovascular and weight management benefits? Do you have any specific exercises to suggest in the water that would help with the above benefits but not fatigue a person so as to struggle to get out of the water?
So let me answer that as best as I could, and I recall that question clearly. The water is fantastic, as I mentioned, and you saw me. That was really me working with someone in the water, and I think it's fantastic. The buoyancy helps lots of people. The input of the water surrounding one's body helps lots of people. I don't know that it is the only way. As a matter of fact, I do know that it's not the only way to do something like this. However, walking in the water is a great thing. Forward, backward, eyes open, eyes closed, sideways, and so forth. The water adds a little resistance, provides a little buoyancy. One of the ways to progress in the water, and it really depends on access to a pool, in particular pools, is you get more help from the water, but as well as more resistance from the water when the water is higher. The lower the water, the more you need to control your own body weight and body position. But very often for people with CMT in the water, when the water's below maybe shin level, some of that resistance against your feet limits the ability to progress through the stages of gait because of pushing your feet into what we call plantar flexion, like a pointed toe of a ballerina, and potentially exacerbating a foot drop. But when it comes to fatigue, and it sounds like the question is really all about fatigue, and whereas walking was enjoyed previously, even 6 miles a day, where now it cannot be, I would first, of course, want to make sure that there are no other underlying comorbidities that are impacting the cardiovascular system, the pulmonary system, and so forth. One of the big things that I think is important, and as I mentioned before, falls and fatigue are some of my big interest levels here, interest areas, excuse me, is efficiency of movement. I might start getting more fatigued because I'm walking inefficiently. A therapist might be able to help you with or without orthoses, braces, with or without regular treatment, maybe some suggestions on being more efficient so that the walking that you do is more efficient and therefore less fatiguing. There are lots of reasons to think that in the presence of CMT, one can improve even potentially lung function, although with some people lung function or breathing through the phrenic nerve and such are impacted. But we can improve our ability for activity tolerance, as I mentioned before. And there's been some literature to show this. So a more direct answer, I hope, to the question, there's a lot of things you can do in the water. Ultimately, what you're going to do, and this is an answer to every single question about which exercise should I do and how much and why and so forth. You need to we all need to start off with a low dose, a low intensity, a small volume, lots of rest, looking at form, making sure that it doesn't cause pain or dysfunction somewhere else, and paying attention to these things. And then you slowly increase these things one variable at a time. For those of you that are parents, you don't give your young newborn or child an apple, strawberries, and kiwi on the same day. Because when they go into full-blown anaphylaxis, when they have an allergic reaction, you don't know if it was the kiwi, the strawberry, or the apple. Same with exercise. I'm not going to have you do lots of new different things on the same day, in the same exercise bout, and then expect to know what caused you to be sore the next day or 2 days after. I want to be very careful with progression, and that's probably the ultimate safe way to exercise even at a higher intensity, whether it's cardiovascular, resistance, functional, for patients' balance, for people with Charcot-Marie-Tooth. Take a look at the progression, monitor the patient, talk to the patient, use outcome measures to see how you're doing. How tired did I get in the pool after a certain amount of activity at a certain level of intensity? Let's rest for 2 minutes. Let's see where your heart rate comes down to. I know this sounds a little bit scientific, and when you're doing things on your own, this might not be possible, but this is why the therapist can help you plan a program, give you variables, you do it, you maybe write something down or you make a mental note, you come back with the information and it has progressed. But to just go ahead and say, go in the pool for half an hour, do your thing, I can't really understand what was done, how to guide someone. For the person with that question, if I didn't answer it satisfactorily, and I'll hope the last time that I say this, but please email me, and I'm more than happy to try to give more information, more relevant information in a timely period.
That really underscores the idea that you really need to be in a partnership with your therapist.
And your physician, absolutely.
And they have to really be engaged to the degree that you've described, where they really analyze or evaluate what you're getting out of the therapies that they're suggesting. And I think that's so valuable for a lot of people. And that kind of leads to the next question that several people have asked, and that is how to find a PT or an OT that knows about CMT and wants to help. Are there any online resources that you could suggest that might allow people to identify the folks in their particular region or area of the country that would be most helpful for them?
So I gave a little smirk when you asked that question for the following reason. I'm speaking to you today, and I got involved with the CMTA because a lovely and dear patient of mine who did very well and we got along splendidly was a support, or is a support group leader here in the New York tri-state area, and connected some dots and connected me with the CMT, ultimately getting a phone call where I got a phone call or I was reached out to where someone said, hey, you're a PT that knows about CMT. You're a CMT expert. Fantastic. We can't find one. I said, hey, I'm not a CMT expert. I'm a PT. I know about neuromuscular diseases. All PTs do. They said, absolutely not. We've been trying to find PTs. We can't find PTs that know anything about CMT. Now, I think that's not true. And as I've said to them personally, and I'll say it, I guess, nationally now, it's embarrassing to my profession that people are coming across therapists that say they don't know anything about CMT. That's not good, and it's still hard to believe. However, besides that, I want to tell you that every single therapist should know about CMT, but sometimes that's not their specialization, and it's not appropriate for their practice. So the American Physical Therapy Association has a website. It's www.apta.org, and you can kind of get into some therapists that might have board certifications. You may want to look at a board certification in neurology and or orthopedics. I don't. My board certification, as I mentioned, is in sports, which is interesting, but that's one way to try to find someone with at least some advanced certification. I think that through the CMTA, you can ask, and they have some names of some people who have experience dealing with patients with CMT, and I would say to ask your neurologist, and I say that with a grain of salt because sometimes the neurologists don't think that this is a good idea, but potentially, and probably I'll say, the neurologist has a relationship or some relationships with some physical and occupational therapists whom they trust, whom they know what they're doing. And even if that person doesn't feel like they're the appropriate person, the neurologist could ask that therapist, do they know someone that really has a keen sense of CMT? And that might be another way to go ahead and find a therapist that has some knowledge and experience in CMT. I'm going to tell you, and this is a link between the last two questions on finding someone and really kind of what to do. In your answer to, or your comment on my last answer, the way in which a therapist would look at things appropriately is actually very difficult in today's day and age, given insurance and given the way things have changed and how much time the therapist can spend with each patient. So it actually becomes harder for the therapist to prioritize what they're doing in a given session and how much time they have to spend with the patient, and that's also something to consider. There are clinics where, unfortunately, driven by reimbursement and driven by other things, that it's a 15-minute time slot that you're seeing the therapist, and how much can they possibly do? Just a good thought is, if in fact you get an appointment with someone whom you think is going to be very good, ask them to send the paperwork to your home so that you can come with it already filled out. And this way you don't have to waste any of your FaceTime kind of talking about and filling out things that you could have done on your own. I hope that's helpful. I know I'm not giving you 5 fantastic names per region, but that's, I think, the best I could do for now.
Let me do a quick follow-up question. If you do get a referral to an OT or PT that is recommended to you, and you meet with them, do you have any particular questions that you might ask them to determine whether they are in fact knowledgeable about CMT?
That's a very, very good question, and it's almost more philosophical than practical, but of course it is a practical question. And this is probably why I think that not only does every physical therapist know about CMT, because we learn about neuromuscular diseases in PT school, but that every PT, even if they somehow don't know too much about it, should be just fine treating a patient with CMT. And it's just like not every plumber is good, and not every teacher is good, and not every gas attendant is good, and so forth. As a physical therapist, I just need to understand what's typical in a particular disease, injury, problem, surgery. I need to realize that not everybody presents typically, and that I need to have my eyes open, don't have any tunnel vision. I need to, of course, listen to the patient and understand what's going on with them. But ultimately, I need to identify deficits, like I said before. So whether you have CMT, whether you just had a total hip replacement, whether you got hit by a car, whether you got hit by a bat and have a traumatic brain injury, what do I want to look at? I want to talk to you and see what you're having trouble with in your life, regardless of the underlying reason. Because I'm not treating your CMT as a therapist. I'm not. I'm treating your functional deficit. I'm treating your inability to cross the street before the light turns. So I'm here in New York City. West End Avenue, where my West Side office is at 69th Street and West End Avenue, is 71 feet across the street. The light takes 28 seconds to turn. So I know that I need to get my patients walking, if they can walk, at a speed that enables them to cross the street before they get hit by the car that's coming. And for those of you who are old enough, that old video game Frogger, trying to cross the street, is not a game that you're supposed to play in real life. So if I identify functional deficits and see what the patient is having a problem with, can they not get up out of a chair? Can they not stand for too long because of pain? Well, how long? What's the goal? Why do they need to stand? They want to be able to cook, and they can't because their ankles hurt. When does it hurt? How long does it take? Are they wearing AFOs? Are they not? How are they standing? Identify the functional deficits and formulate a treatment plan that will help to remove those deficits and gain function. As long as I understand the potential implications of a disease process, injury process, surgery, it really doesn't matter. Now, yes, do I have to think about overwork weakness, as I talked about? Of course. But no smart therapist will tell any patient, regardless of neurological disease or not, to start jumping up and down as exercise if they haven't even walked well, if they haven't even done a little mini squat, if they haven't stood in a certain way. I know it sounds like I'm making it so simple. In my mind, it really, really is. Talk to the therapist and try to understand their philosophy. Try to understand their approach to patients. If it sounds too cookie cutter, yeah, you hear what we do is we go on the bike, then we get a hot pack, then I put some electrical stimulation on you, then I pat you on the tush and I say goodbye. Well, that's not skilled therapy. That's just in and out. Are some of these things very important and incredibly relevant sometimes? There's no doubt about it. But take a look at this for a second. I think this is a great picture. Why do I think it's a great picture? Because she's stressing her wrists in a way that most people probably shouldn't. Her head is forward away from her body like it probably shouldn't. Now maybe this is before the therapist said, hey, Diane, please remember to make the back of your neck long and contract your abdominals to change your pelvic position and so forth. But maybe this is not good. You want a therapist that's going to look at the quality of your movement, identify functional deficits, and try to make functional change. How to get that from a brief interaction or one question, I'm not sure, and I apologize for my rant, but it's very simple. It's not particularly CMT related in my opinion. You need to have a smart, intelligent person who maybe needs to read a couple of articles, needs to look up some information. But if they're trying to identify deficits and trying to improve function, understanding that some of the underlying pathology might push them towards one direction or limit something else, you found a good therapist.
That's great. Thank you.
Sure.
The next question has to do with specific exercise machines. And
Yep.
It goes, what do you think about inversion table therapy for sciatic and back pain? What do you think about Burdenko water therapy exercises? And do you recommend working out on health club machines for the legs and calves?
So these are incredibly specific questions that I cannot answer for someone whom I do not know. However, I'll make some general comments. The Burdenko method is a fantastic aquatic therapy method. I'm very pro the Burdenko method. But as I said before, you can't only go into the water. And I actually used to teach aquatic therapy classes, and I stopped because my colleagues, and this happens in a lot of areas of therapy, I think it happens in a lot of areas of life. When you are under a particular school of thought, you tend to be a diehard. And no, this is the only way to do it. It's not the only way to do it. As I mentioned before, we do not live in the water, so we need to get out. But I do like the Burdenko very, very much, and particularly for lots of patients with CMT. Inversion tables for sciatica, I don't think that's even necessarily CMT related. The only relevance particular to CMT would be the fixation. And for those of you who are not familiar, an inversion table is basically an upside down table. It kind of like flips you upside down. Very often the restraint, or what limits you from crashing down on your head, is straps around your ankle. So that's of course something to think about for people who have had surgeries, people whose skin or the sensation is not what it might otherwise be, and therefore they wouldn't know if it's cutting off their circulation or digging in too much, and so forth. As far as the appropriateness of inversion tables and traction or elongation of the vertebral segments to relieve pressure on a nerve, that's something that helps lots of people. I happen to not have nor use an inversion table. I like to do manual traction so that I can control how much what's happening and then let go if necessary. The way in which we do that is we have patients lie supine on their back on the table, holding their feet, ankles, calves with their hips angled up, holding their legs up a little bit, kind of at about a 30-degree angle, and then pulling away. That lines up the lumbar spinal segments a little bit more vertically and enables us to open them up and potentially decompress a nerve. I don't think that there are some crystal clear, straightforward correlations with the CMT population that wouldn't be relevant. I don't think it's very, very different, other than the fixation method or the fixation location and method that I mentioned before around the ankles. I don't think it's very CMT specific. I believe the last question, and please jump in if I'm wrong or if I'm missing one, was about ankle machines and plantar flexion, tippy-toe type machines in the gym. Again, it depends who the patient is, how much weight, and so forth. Like I said before, there seems to be, in my opinion, in the relatively uneducated or misspoken population that says, oh, use body weight versus machines, that's safer and better. Not necessarily. If my ankle strength and my ability to stand on my feet, on my toes and push down, let's just say, is limited, well then my body weight might be much more than if I put myself on a horizontal platform that can move and put my feet, I don't know if my hands are showing in the camera very well, up against a platform, and I'm just pushing my toes down and my body's sliding sideways. It's not with the full effect of gravity. That might be a great way to, number one, work on my plantar flexors, my calf muscles, to strengthen as I come back, to elongate my Achilles tendon and my calf muscles to gain more range of motion. Maybe such strength and range of motion, that would be too much if I was standing up with full body weight, and certainly standing full body weight with the machine at the gym. Maybe. I don't know if the question was related to those seated machines where your knees are bent and your ankles are fixed, or your forefoot is fixed on a platform and your heels go down and then you push up. It's a very, very different exercise because the knees are bent. And for the calf muscles, the gastrocnemius muscles actually cross the knee. So when the knees are bent, you're using more of another muscle called the soleus, or maybe even if you're not using more, you're limiting the elongation of your gastrocnemius, your calf muscles, and it's a totally different exercise. Rick, please jump in if I didn't do justice to those questions.
I think you did. If I might summarize, what I heard was that the equipment and different types of therapies really are best evaluated by your OT or your PT. And whether the equipment's at a health club or a gym, it doesn't really matter so long as it's exercising your muscles in the way that your OT or your PT recommends.
I would mostly agree, and ultimately when someone's going to go to the gym and do stuff on their own, it should be under the, I don't want to say guidance and supervision, because maybe they don't have the ability to go and to take a look once. We always try to send the therapist to the patient's gym, if the gym would allow, one time after they've discussed the program, to say, here, let's go through it and see, make sure you can get on and off the machine appropriately. Let's see how you do it. Let's see how you press these buttons. Let me see how hard it is for you, to make sure that it's the appropriate thing at the appropriate intensity at the appropriate time and so forth. But for everybody, it's going to be a little bit different, and what's going on with them. And certainly we don't want people to waste their time. Once you're giving your valuable time to go to the gym, you want to use it appropriately, you want to prioritize, and you definitely don't want to hurt yourself.
That's a great answer. The next question has to do with the concept that when someone with CMT loses muscle, they can never regain it. The question is this a myth or is there some truth to it? That concept has been circulating within my family, and some of my family is reluctant to use their AFOs for any length of time because they believe they'll lose muscle and never get it back. Also, my 8-year-old grandson with CMT type 2 will soon have tendon transfer surgery on his foot. He'll be in a cast for 6 weeks. Will the muscle mass he loses during that time be permanently lost?
So, I'm sorry, you're all set?
Yes.
Okay. There's debate. There's debate in the literature. There was one study that I cited before, I think it was a Chetland study, that showed actual muscle fiber changes with resistance activity, positive muscle fiber changes with resistance activities. I'll tell you anecdotally, my personal experience with patients, I've never seen a patient who's exercise. I have patients who exercise to maximum intensity, meaning they cannot do more. They work as hard as they could. We rest, we recover, and we work again. Maximum. Pushing, pushing, pushing. We didn't start that way. We started at a 2 out of 10 rate of perceived exertion, and as we moved up and as we monitored variables, everything was fine. Nothing got worse. Things only got better. But I did not see in this patient or others a very clear visual hypertrophy, muscle growth. What I did see visually was functional improvement. Where's that functional improvement come from? Maybe compensatory strategies, maybe movement efficiency, maybe hypertrophy and strength in other muscles that are not as affected or whose nerve innervation is not compromised. I don't think there's a clear answer as to can you reverse, can you slow the progression. I do think there's a fair amount of thought that for people that are very active as children, play, exercise, and so forth, have better results as adults. But I don't know that there's a crystal clear answer to that, and I can't tell you that there is in terms of muscle regeneration and so forth. After surgeries, it of course depends on what was done. Minimizing edema is incredibly important because there is actually edema-induced atrophy, if you will, or really muscular inhibition. And muscular inhibition is something that happens in the presence of edema and will inhibit muscle firing, which will ultimately lead to atrophy. And this is a very, very important point, not only related to surgery, but important to everything that we're talking about. And Geeta Rendry out of the UK talks about this in some of her articles, and I think it's a very, very important point. Are what we're talking about is primary weakness or secondary weakness? Is the weakness due to my CMT and the problems that I have from the disease to my muscles? Or is it because now I've shrunk in my world and I haven't done as much and I'm more sedentary, so now everything starts to kind of go down? That latter part, that secondary atrophy, weakness, and so forth, is the easiest thing to address. Whether the muscles are going to come back, I don't know. I can't tell you. I'm not sure that there's fantastic literature. If you put a gun to my head, I'm going to tell you I wouldn't bet on it. But I know you can improve function. I've seen it time and time and time again. And if we can limit the effects on immobility, on sedentary behavior, on inactivity resulting from the primary cause, and not let it get to the secondary shrinking of the world, I'm not going to go out anymore, I'm too tired, I'm just going to sit here, then the choices, as we started off with, are lost. And exercise, appropriate therapy are all about expanding the world, giving the patient choices, improving quality of life, independence, and mobility. Hopefully that was decent. I think there was one part of the question that I did not answer, although I'm not sure.
I'm not sure either. But I would like to ask you whether you have an opinion on the kind of widespread thought that using AFOs immobilizes your ankles or your feet to the degree that there is an effect and an acceleration of the deterioration of your muscles. I know that some doctors like Dr. Shai believe that that's probably not true, that it's very difficult, of course, to separate out the progression, the natural progression of CMT from effects that might arise from using using support devices like AFOs.
So thank you for bringing that up, because that was in the back of my mind what I didn't address well enough. So these never and always, very dangerous words, as mentioned before. And there are a lot of different kinds of AFOs. And there are a lot of different kinds of ways to immobilize, to promote mobility, dynamic splints, and whatever else. I think the underlying thought here is that if that my brace, my orthosis, my AFO doesn't let me push down, or doesn't let me try to push up because it's just holding me in a given position, so therefore I won't do it, and the muscles that will potentially enable me to do it are going to weaken, deteriorate, atrophy. And I think, at least conceptually, there is something to it. Of course, the orthotists, the neurologists, the physiatrists, the therapists, when recommending bracing and such to their patients, keep that in mind and try to limit the limitations to promote mobility and work. Sometimes it's what you do outside of your braces that can deal with it. I don't know that I would say that braces in and of themselves are bad from that perspective. What I do know is that I've taken many of my patients out of their braces, because I find very often that we can get them to be more mobile without. Of course, discussing with the neurologist, with the orthopedist, making sure that we're not going to put them in positions now that are going to give them more musculoskeletal and neuromotor challenges because of it. But to me, being able to feel the floor is such an important thing. I mentioned before the falling and fear of falling and immobility and this whole shrinking world concept. There's a researcher, and I apologize, whose name I forget, who talks about the following. And I'm going on a tangent, but I think it's relevant enough, and since I'm talking, it's too bad. I heard this from Patricia Painter, who's a fantastic exercise physiologist researcher with a focus on patients with kidney disease. And I've done some work with her. Wish I could do more because she's brilliant and she does a lot. The concept is as follows: active days. We all are born, and I would love to have a graph and show you this. We're all born, and if you think about the intersection of the X and Y axis, we can't do anything for ourselves. We're completely dependent. We come out of mommy, and we're just lying there. We can't do anything. Not much is expected of us. We need lots and lots and lots of help. And the x-axis is time, and the y-axis going up is function, our ability to do stuff for ourselves. So there's no time. We were just born, and we can't do anything. There's a pretty steep progression going up at first. We start getting older. We're hitting milestones. We're doing more for ourselves. We get into our later teens, and maybe we're almost, fully independent. Early 20s, we have a job. Maybe the parents out there, please, I want my kids to be independent, and now they're independent. And they're independent physically, emotionally, and so forth, maybe. But certainly there's a direct ascend of the line. And now we're 25, 30, 35, and our ability physically to be independent is kind of static. It's kind of going across until it starts to go down, let's just say in the absence of disease. And then we start getting older, things start happening whenever they do, and it starts going down. And for lots of us, it starts going down, maybe steadily, maybe real steep because something happens, and then ultimately it starts getting really close to the bottom, and it starts kind of going down for lots of us. That's not what we want. I think that most of us would want to have a lot of active days, and we want that graph to go up, stay across, and then come right down when we die and we're done as much as possible. How do we do that? By being active. By promoting activity through exercise, through therapy, through function. If we don't do exercise therapy when we have a neurodegenerative disease such as CMT, our world will shrink on us. We will not be able to go out even if we want to, and we're going to have, unfortunately, a long period being really close down to the bottom. Quality of life. For some people, that's okay. And I can't make that decision as a therapist. That's why I need to listen to my patients. And I know this is a tangent, but it's something that I think is very, very important. Understand what people want to do, what makes them happy. If someone wants to have a brace and orthosis so that they can do this, that's fantastic. Everyone's different. Do I think, and I'm getting back to the question at hand, do I think it directly causes muscle loss? I don't think so. Do I take some patients out who spent a bunch of time in? Yes, I do. And I kind of apologize for the tangent, but not so much.
It's quite all right. A couple of questions asked about supplements. Do you have any recommendations as to vitamin supplements?
No clue. No clue. I'm not your man. I don't know. I have heard that there are people that do all kinds of things that are very, very helpful. I'll just tell you one thing about supplements, and this is not to compare what I'm about to tell you to supplements. It's more to tell you that I don't know and I don't understand. I had a patient with peripheral neuropathy. He actually not CMT. He actually has CIDP, chronic inflammatory demyelinating polyneuropathy. 10 out of 10 pain in his feet, couldn't wear socks, couldn't wear shoes, couldn't have blankets over his feet, horrible. We did a lot of different things. He went down to 2 out of 10, was the happiest camper. I think we actually came at the right time. I can't necessarily take all the credit there. And then he couldn't come, he traveled, there was death in the family, so forth, and we were emailing back and forth, and it came back, and it was terrible. And he emailed me that he now is pain-free. What happened? Someone told him to take soap, a bar of soap, and put it under his bed. And the soap made his neuropathy go away. So what kind of soap? Special soap? Any soap. You could use any soap. I don't know. Doesn't make sense to me. I just don't know enough about supplements. I would assume the best thing to do, maybe the neurologist knows, talk to an RD, a registered dietitian. I don't know. Sorry.
Fine. Next question is, what is the correct way to lift and protect the low back from strain and injury when those of us with CMT do not have the strength in our legs to squat and lift? Also, is there any correlation between CMT and piriformis muscle problems in the pelvis?
Okay, so let me attempt to answer this, and I might ask you to repeat some of this. The correct way to lift, CMT or no CMT, is by stabilizing your lumbar spine through your transversus abdominis and your pelvic floor and your multifidi. Okay, let's talk English now. Your lumbar spine is in all of our abdominal cavity. It's between our pelvis and our chest, kind of in our belly area. And it's much closer to the front than people think. And how do we stabilize our lumbar spine, and in what position do we want to keep it? Usually neutral. Usually not too forward, not too back, and without showing, I can't necessarily tell you these things, not too arched, not too much the other way. And for some people who are in one direction, we tell them go as far as you can in the other direction and vice versa. By bringing one's belly button towards their back without holding your breath, even though sometimes if you're lifting heavy, holding breath is important for stabilization, and contracting your pelvic floor, like a Kegel exercise, you're now bringing some stability to the front of this abdominal cavity. You're bringing stability on the floor. Your diaphragm above is not going to do too much if you're controlling your breathing, and your back is your back. There are bony restraints there. And you're creating higher intra-abdominal pressure that will help to stabilize the lumbar spine. It's not only the lumbar spine, there's other things, and there's more to discuss, of course. Keeping it long and keeping it stable, moving from the hips, hinging at the hips. There are many people with CMT who present to me no different than someone without CMT as it relates to this. It's usually, in my experience, the ankles that potentially are limited and therefore don't allow someone to have what we call an anterior weight shift, to lean far enough forward to be able to do a good squat-like maneuver where they're using the muscles of the calves, of the quadriceps, of the hamstrings, and of the gluteals with stability going on through the back. So the way to do a squat is to not let the knees travel over the toes, to align with the second toe, to hinge a lot at the hips, to descend carefully, slowly, without the knees going in or out. Try to think of the knees being like hinges and just kind of going up and down. Maintaining stability through the abdominal wall and pelvic floor for the lumbar spine, and start with small little motions. Don't go all the way down. Don't even go on a chair. Go do it off of a high bed and do it nice with control, with small numbers of repetitions. I'm not telling anyone to do this with your therapist, but this is the way you progress, and make sure that as you do more, or as you do go deeper, or as you do it for a longer period of time, you're not compromising form. Please just tell me there was another little portion there that I didn't answer, I know.
There was a part of the question dealt with piriformis muscle problems, which I'm not familiar with.
Yeah, so I don't know if I've never heard of a particular piriformis link to CMT. I've never heard of it.
Okay.
We all have piriformis, but whether it's problematic or involved with CMT versus someone without, I never heard of it. I could be wrong.
In your answer, you made mention to Kegel exercises, and I'm pretty sure Kegel spelled Kegel.
Correct.
But I don't feel qualified really to describe what Kegel exercise is. Could you just give a quick explanation of that?
Yeah. So what I'll do, and I'll kind of close with this, is as follows. In trying to stabilize the spine, and really in trying to do, well, you know what, here's what I'm going to do. I'm going to answer your question. I'm going to kind of broaden it out to why it's important, and I'll come back to it again. Kegel exercise is when you contract your pelvic floor. For a woman, some of the vaginal muscles, some of the perineum, the musculature between the vaginal opening and the anus. For a man, the area pretty much behind the scrotum to the anus. If you think of your pelvic floor, it's kind of like a hammock that goes from your coccyx, from your tailbone in the back, and it scoops around in the front to your pubic bone in the front on top of your genitalia. And think of it as like a sling. It hangs down. And can you see my hand over there? It kind of hangs down from your back over here and in the front on the other side. I want this to go up. I want it to go up and contract these muscles. Squeeze these muscles as if I'm making the canals tighter. And this way, I'm engaging these muscles so that the floor of this abdominal cavity, and think of this cavity as a cylinder, with the bottom being your pelvic floor, the top being your diaphragm, the front being your abdominal wall, and the back being your back, as we call it. Contracting these muscles will elevate this floor, lift this floor, and prevent intra-abdominal pressure from pushing down against the floor, which gives some people vaginal, rectal prolapse, different sorts of incontinence issues, sexual dysfunction, and so forth. Ultimately, why are these things important, including the abdominal wall, is for proximal stability, for distal mobility. Sounds nice. But if I want to be efficient in my movement, I want to move the parts that are supposed to move and not move the parts that are not supposed to move. If you and I were going to have a bowling ball throwing contest, and the winner of the contest was going to be guaranteed health, wellness, and all happiness and fantastic stuff for the next 30 years somehow, and we believed in it for whatever reason, we're going to be trying pretty hard to win this bowling ball contest. We're going to train. We're going to do whatever we can. And ultimately, they're going to take this bowling ball and they're going to, they're going to say, whoa, James said he weighs 225 pounds. That's not fair. He needs a heavier ball. Rick needs a lighter ball. We need to look at their age, their diseases, and they're going to kind of make the ball the appropriate size for each of us to make this fair. And they're going to say, all right, throw the bowling ball. Whoever throws it farther is guaranteed to have all the great stuff. And Rick, you get to throw the bowling ball standing on the floor wherever you are right now, and they're going to measure the distance. And I have to stand in a rowboat on the lake, and I'm going to throw it, and they're going to measure the distance. Well, we all know who's going to win. Because a lot of the energy that I'm going to try to produce throwing the bowling ball away from me is going to dissipate into the floor, into the water, because of all my instability. I want to have stability off of which to get good mobility. If I am not stable and other things move, I lose some of my energy through all of that excessive motion. If I can stabilize my lumbar spine, one of the components are through pelvic floor activation, then my mobility and my other movements are going to be more efficient, and more useful. The same thing goes in fatigue and walking, like we answered the person's question about walking the 6 miles before. I might not be walking efficiently. I might be all over the place with my gait for imbalance, for who knows what. Well, that takes more energy to control. If I can control some of these things, I might be able to be more efficient, less fatigued. One of those steps, Kegel exercises or pelvic floor to be able to stabilize the abdominal cavity for the lumbar spine.
I'll tell you, when you describe this, James, it's so visual and rich. I really am grateful for how much thought you put into really explaining, difficult concepts and motions that ordinary, I think PTs and OTs can kind of skip over or not even realize that they haven't fully described it because they're so close to the subject. So thank you very much for that.
You're very welcome. It's my pleasure.
We're about 90 minutes into this webinar, and I think that it's probably best if we don't address all of the remaining questions and invite people perhaps to contact you directly or write to the CMTA for further answers to questions that may not have been addressed. But I'd like to kind of combine 3 or 4 questions here that ask about very specific treatments and roll those up as our final question of the webinar. These questions ask about Bikram yoga, which is the hot or hot temperature version of traditional yoga. They ask also about acupuncture with electrical stimulation, and also something called Tommy Copper knee compressions. The questions obviously address whether any or all of these therapies have any, whether you believe any of these have potential good benefits for CMT patients.
Okay, so let me answer in the following way. I don't know of any study or well-designed study, take that with a grain of salt because there's not enough studies, as we mentioned before, in more traditional areas of acupuncture with electrical stimulation. Do I think it doesn't work? I don't. I'm not saying that I think it doesn't work. I don't know. Might it work? It might. And there's so many people that rave about the benefits of acupuncture. So if their neurologist says that it's not going to hurt them, hey, hell, give it a try. I have no idea. The last thing that you mentioned I've never heard of with the bead compressions, I have no idea what it is, so I'm sorry I can't answer. Bikram yoga is interesting. I've actually done Bikram yoga myself. And I don't see why it should be a problem. I think that maybe one of the reasons why people are concerned is because with MS, with multiple sclerosis, also a neurodegenerative disease, there are some issues with getting really hot. And every Bikram place is a little bit different. And some of the instructors can be rather harsh on the participants. And it's, I think, usually 104, 106 degrees in there, and it can get pretty intense. The thing that I would think is most dangerous, if you will, about doing Bikram for someone with CMT is that you need to know beforehand that when the intensity of the effort or the heat, the exercise becomes too much, that you're going to be able to walk out of that door because sometimes they won't let you leave, in my experience. And that's not okay because you're going against the principles that we described before. As far as tissue mobility, heat, and exercise within heat, sounds like it would be a great thing. But just like everything else, it needs to be done slowly with careful progression. And you need to plan it beforehand. Just like I wouldn't say go water skiing because maybe you're stuck out on that boat and you're out there and you're going to try to stay up and you're going to have a lot of vibratory input and a lot of taxing of the joints and so forth. The volume, the intensity needs to be controlled. And if you feel like you could control that in Bikram yoga and you can start out by doing 2 minutes, 3 minutes, and then stopping, seeing how you feel, I would say go ahead and try. I see no reason not to. But in the absence of having that control and that ability to monitor and carefully progress, it's a terrible idea just like anything else. And with that, I'll I'll really say thank you so much for addressing the questions and for compiling them, and thank you for all of you who put it in there. Please feel free to email me. I can't promise you that I'm going to be super quick on my responses. I will certainly try. And I thank you for this opportunity to share some of my opinions. Please once again understand that a lot of these things are my opinions and not necessarily fact, but to repeat, every single person with CMT should have a PT and an OT evaluation. Every single person, no matter what anyone else tells you. I'm happy to tell you that that's a solid 100% true statement. Should have the evaluation.
Well, thank you very
so much, everyone. Have a great afternoon. Happy holidays. Happy New Year to everyone.
Thank you very much. I think I speak on behalf of everybody that's participated today in thanking you for putting so much thought and providing so much of your time for our benefits. Thank you very much.
You're very, very welcome. Take care. Bye-bye. Thanks for your help, Rick.
I'll also remind everybody that this presentation was recorded and it will be available for viewing or even downloading at the cmtausa.org website within a week or two, along with a transcription of everything that was said in the webinar and a copy of James's slideshow that accompanied his presentation. Look for that within the next week or perhaps 2 weeks at the latest. Thanks very much, and look forward to the next webinar, which should be in about a month, and we'll notify everybody as to what's going to be presented in that webinar, and hope you can attend. Bye-bye.